I'm Mary Ann Mavernack, the Andrew H. and Janet Dayton Neely Dean of River Campus Libraries, and I'm delighted to welcome you this evening to what we believe will be an outstanding Neely Lecture made possible by an endowment by Andrew H. and Janet Dayton Neely. We're very grateful for them for this series. In recognition of World AIDS Day and to share with you some of the extraordinary posters from the AIDS Education Poster Collection collected by Dr. Edward C. Atwater and housed in rare books and special collections of the River Campus Libraries and fully online, we have asked Professor Gerald Oppenheimer to reflect on the AIDS epidemic from a historical perspective in the United States. To introduce our speaker this evening is Professor Ted Brown, Professor of History, Medical Humanities, and the Charles E. and Dale L. Phelps Professor of Public Health Policy. Ted?
Thank you, Mary Ann. Well, good evening. Thank you all for coming. It is a great personal as well as professional pleasure to introduce our speaker this afternoon, Dr. Gerald Oppenheimer. The reason for my professional pleasure will become obvious shortly, but I'd like to take a few moments to explain my personal gratification. We are old friends, and we first met many decades ago, but don't count them, in a classroom at the City College of New York. We were undergraduates in a required Western Civ course. I, a sophomore, and Jerry, a freshman. Our instructor was the amazing Larry Levine, who was then finishing his PhD in history 2 subway stops away at Columbia University. Larry later went on to a distinguished career as an American cultural historian at the University of California at Berkeley. That class inspired Jerry and me and several others who were in that class and were inspired as well. And when we graduated, we headed west to graduate school. Neither of us got as far as California, but Jerry got to the University of Chicago for his PhD in history, and I made it all the way across the Hudson to a doctoral program in history of science at Princeton. Jerry and I took different paths in the 70s and 80s, but we got reacquainted in the 90s after some interesting transformations that had turned us both into historians of medicine and public health. And we started seeing one another regularly at editorial meetings of the American Journal of Public Health. We both served as editors in the 90s. We have become close friends, and I treasured Jerry as one of the nicest, funniest, and smartest people I know. So let me get back to the professional side and give you a glimpse of what he's so smart about, as you'll soon get plenty of evidence for yourself. Let's start with the mid-70s, after Jerry had earned his PhD at the University of Chicago. There wasn't much of a market then for French Enlightenment historians. So after a couple of teaching gigs at a variety of colleges in the Midwest and in the New York area, Jerry decided to take a job as a health systems analyst with the New York City Department of Health and to go back to school, this time to earn a master's in public health from Columbia University. He earned that degree in 1979, and he followed that with a postdoc in epidemiology, also at Columbia. With his new expertise, he took a job with Empire Blue Cross and Blue Shield, and from 1980 to 1986, worked his way up from senior research associate to director of project management. In 1986, he was offered a position as associate professor in the Department of Health and Nutrition Sciences at Brooklyn College of the City University, and he has been there ever since, working his way up to full professor. He has also become a member of the CUNY graduate faculty in Mid-Manhattan and as a professor of clinical public health at the Mailman School of Public Health at Columbia University. Jerry teaches a lot, incredibly well, at every level from undergraduate to graduate and postdoctoral at all 3 institutions. It's quite a juggling act. From 2007 to 2012, He also held a distinguished Brooklyndian professorship of public health at Brooklyn College and the CUNY Graduate Center. During those years, from the mid-'80s onward, Jerry established a considerable scholarly reputation by publishing an exceptional body of work impressive in both quantity and quality, mostly at the intersection of the history of public health, ethics, and health policy. His most important work has been in the history of HIV/AIDS and in the history of epidemiology. His work on HIV/AIDS began in the late 1980s and early 1990s with a vengeance, with a series of book chapters and pioneering edited volumes on AIDS history. As a sole author and collaboration with others, Jerry published essays on several important topics, such as the role of epidemiology in the historical construction of AIDS, the role of AIDS in the gay community, and AIDS and health insurance. He then moved on to a series of historical articles in major peer-reviewed journals, such as the Journal of Health Politics, Policy, and Law, and the famed New England Journal of Medicine. Finally, with Ronald Bayer as a co-author, Jerry has produced 2 major books, both published by Oxford University Press, both actually on display at the table in the back. And those books are, first one in 2000, AIDS Doctors, Voices from the Epidemic, and one on South African AIDS physicians called Shattered Dreams, an Oral History of the South African AIDS Epidemic, which came out in 2007. By the late 1990s, Jerry has also begun a second major line of research on the history of epidemiology, beginning with papers on the historical epidemiology of tuberculosis, on race and ethnicity as statistical and epidemiological categories, and starting in 2005, on coronary disease epidemiology. In 2005 and 2006, he published major papers on these topics in the American Journal of Public Health and in the International Journal of Epidemiology. Jerry's impressive funding support for his historical work on HIV/AIDS and coronary disease epidemiology is another indication of the extraordinary quality of his work. For his AIDS history work, he has received substantial grants from the National Library of Medicine, the Royal Marks Foundation, the American Foundation for AIDS Research, and the Rockefeller Foundation. For his work on the history of coronary disease epidemiology, he has received major grants from the American Legacy Foundation, the National Library of Medicine, and the National Endowment for the Humanities. Eye-hand coordination is everything. Yeah, did it. So I could go on, but I won't. Professor Gerald Oppenheimer will now address you on the question of death, stigma, and commitment, the AIDS epidemic, 32 years and counting. Professor Oppenheimer.
Okay. Thank you, Ted. I'm taken aback, and I hope to live up to your description of me, but thank you very, very much. I want to thank you all for coming this evening. I want to thank all of you for inviting me to speak to you at the University of Rochester. And I want to also mention, I know he's in the room, the wonderful collection of Dr. Atwater, who was prescient enough to collect posters from the very beginning of the epidemic. Oh, there you are, sir. Remarkable collection, and I look forward to seeing it. I've only seen it on the web. So, can you hear me? Is my mic on? Yeah. Okay. Tonight, because of the magnanimity of Edward Atwater, we celebrate a magnificent collection of AIDS posters, artful reminders of the long, ongoing campaign to prevent or limit the devastation of a horrible, painful pandemic. Globally, the disease continues to ravage populations in Africa, Asia, and elsewhere, but in the United States, AIDS has become almost invisible, and the unique AIDS politics has almost disappeared. New reported cases of HIV, or really AIDS, remain about the same every year, 40 to 50,000. A cocktail of antiretroviral drugs and expert clinical care has transformed HIV/AIDS from a death sentence to a manageable chronic disease. And the media barely mentions AIDS except on anniversaries. AIDS issues in this country now revolve around the usual health systems, health issues, around the question of healthcare finance and treatment access. Along with AIDS politics, we are seeing the end of what Ron Baer called AIDS exceptionalism. Exceptionalism sought to avoid the traditional authoritarian dimensions of public health in times of health crises in order to gain the trust and cooperation of those, particularly gay middle-class men who are most at risk of the disease. Today, to identify the 25% of HIV infected who don't realize they are seropositive, it has become federal policy to favor mandatory opt-out HIV screening for those between the ages of 13 and 64, a fundamental change from previous policy, which stressed voluntary testing along with confidentiality and pre-test counseling. Successful treatment and more intrusive screening are both associated with a marked decline in HIV stigma. I personally know people who regularly, quote unquote, out themselves as seropositive to students and colleagues. But the waning of AIDS exceptionalism may also be tied to another factor. Like most infectious diseases, this one is spreading most among the poor, among minorities, who lack a unique and strong political organization. In brief, in so many ways, HIV/AIDS has become normalized, if not tamed. How different from the world from which the AIDS posters emerged, in which a disease of unknown origin and mode of transmission silently entered communities, and then with epidemic ferocity killed hundreds of thousands of young and middle-aged people. It is, in a way, unsettling to contemplate posters, however beautiful, abstracted from their original context. As we view them tonight, we should also remind ourselves, to paraphrase Camus in The Plague, they are a record, quote, they are a record of what had to be done and what will assuredly be done again, end quote, to check the spread of contagion that churned through communities, values, medicine, and every major American institution. Let us recall what they testify. The new disease, the new disease, as its dimensions seeped into the consciousness of even the most inexperienced doctor, chilled them. In early 1981, Donna Milvan, chief of infectious disease at New York's Beth Israel Hospital, who had noted for some years the appearance of swollen lymph glands in a cohort of her gay patients, these swellings without apparent cause, and who had just lost 2 young patients to diseases that signaled an impaired immune system, ran into her colleague, Dan William, on a street in New York. And this is her story. He informed her, Donna, You're not going to believe what I have to tell you. 3 patients of mine have Kaposi sarcoma, gay men, for no reason. And that too is the disease of immunocompromise. All the color drained from his face, and we were both speechless. We really saw the whole thing written out before us. We couldn't have dreamed of what the proportions would be, but we were scared. We were really scared. June 5th, 1981, months after this interchange, marks the official start of the human immunodeficiency virus, the HIV virus epidemic. On that date, the Centers for Disease Control published what has become a landmark communication in its Morbidity and Mortality Weekly Report, the MMWR, written by Michael Gottlieb, another infectious disease doctor, and colleagues. It alerted the public health community that between October 1960 and May 1981, 5 young and previously healthy homosexual men have been treated in Los Angeles hospitals for pneumocystis carinii pneumonia, PCP. From this information, the CDC suggested a possible link between PCP and homosexual sex or lifestyle. As if to reinforce that point, Gottlieb's paper was closely followed by another from New York and San Francisco. It reported that in the 30 months preceding July 1981, Kaposi sarcoma, KS, had been diagnosed in 26 gay males, 26 to 51 years of age. KS was known as a rare cancer that occurred primarily in elderly men and in immunosuppressed organ recipients. Its appearance in a relatively large number of young men was startling, as it was that of PCP in individuals without a clinically based cause for immunodeficiencies. As they read of the reports, doctors on both coasts recognized similar patients who had passed through their waiting rooms and their services since the late 1970s. Others remembered young patients who had died of infections that were difficult to diagnose and devastating in their course. Over the next 18 months, the news of the burgeoning epidemic became darker, heralded by the headlines of the MMWR. On July 9, 1982, the CDC announced that Kaposi sarcoma and opportunistic infections had been diagnosed in Haitians. A week later, the MMWR reported PCP in hemophiliacs. On December 10th, it alerted its readers to the possible transmission of the new disease, now called acquired immune deficiency syndrome, or AIDS, through blood transfusions. On December 17, 1982, and January 3, 1983, respectively, the agency reported unexplained immunodeficiency in infants and in female sex partners of men with AIDS. What emerged was a profile of the epidemic as the burgeoning of a new sexually transmitted and blood-borne disease. But the landmark reports of the MMWR tell us only part of the story, the seemingly ineluctable evolution of the outbreak. Nonetheless, in the first years, even that minority of doctors who would commit themselves to AIDS had no reason to believe that the grim clinical picture would produce a grave social burden. As the epidemic took off, there was reluctance on the part of many to acknowledge its potential proportions. Donna Milvan recalled years later that, quote, everyone was resistant in stages. The first decade of the epidemic was characterized by one contemporary physician as medieval. How far into the population the disease would spread, nobody knew. Public interest, reflected in the mass media, oscillated between indifference and panic. Fear of infection by risk groups produced widespread discrimination in the workplace, at schools, and in medical facilities. For American medicine, the outbreak represented a startling reversal. After decades of medical advances, doctors were now confronted with a disease that seemed to parry their interventions. They had managed, of course, other incurable conditions. But what rendered AIDS so different was that it was an infectious threat, something that physicians in the U.S. had come to think of as chiefly an affliction of the less developed world. In addition, it primarily struck down the young, inverting the natural order of things in advanced industrial countries. As in war, the old were burying their children. The advent of AIDS forced doctors to face the most basic questions. If I cannot cure my patients, what can I do? What is my role as a doctor? And what is my duty to patients who pose a threat to my own life? As doctors sought answers to these questions, they had to reflect on professional experiences before antibiotics, when healers routinely fell victim to contagion. And they had to do so surrounded by a degree of suffering for which few of them had been prepared. In describing his patients in the first years of the epidemic, for example, one physician noted, "We didn't have anything for them. They died. And the deaths they died, I recall, were very terrible deaths. They were deformed, disfigured, and wasted away. Chaos lesions all over their bodies." No training was sufficient to prepare physicians for the number of deaths they encountered in this new epidemic. The mortality statistics for an infectious disease in a developed country were staggering. In 1981, 120 fatalities were recorded, probably an undercount. 5 years later, accrued deaths had risen to 12,000. By 1990, that number stood at 100,000, almost a third in that year alone. AIDS became the leading cause of death in men aged 24 to 44 in 1992, the fourth leading cause in young women. But for young black women, it was the leading cause of death in 10 American cities that year. Infectious diseases they use as possible models of AIDS, like hepatitis B, at first led doctors to hope for a limited case fatality rate. This proved to be another form of denial. By 1987, they understood, given the epidemiological data and their own experiences, that AIDS was almost uniformly terminal. By 1995, a Manhattan-based private AIDS physician could report our cumulative total of AIDS deaths was just over 500 cases by the end of 1994. For any physician of primarily young people to have ushered 500 to their deaths is an extraordinary experience. In Los Angeles, Joel Weissman, a co-author of the first MMW report, estimated he had lost 1,000 patients by 1995. One AIDS doctor recalled that when he encountered a new patient, still strapping and attractive, his response was, "I'm looking at a healthy dead person. It's just a matter of time." Since death was almost inevitable, physicians sought to demonstrate their professional mastery by organizing their patients' dying and death. What that meant varied: controlling pain, helping a patient come to terms with the stigma of AIDS and the trial of dying, reconnecting patients and families, and helping all to recognize when further interventions would be futile. Reconnecting with centuries past, doctors spoke of orchestrating a good death, one in which their patients died with some dignity despite the ravages of the disease. Gerald Friedland, who treated drug addicts, IV drug users in the Bronx, recalled, "We would preside over their cruel deaths. And in a stigmatized, unknown disease, it was quite a trip. But I got very good at organizing people's deaths in this way, in this very complicated and painful and unknown situation. You've got to get the person to be at peace with himself or herself and deal with issues of blame and guilt and death and dying." To therapeutic limits and unending fatalities, another burden was added to those doctors and nurses who committed themselves to caring for AIDS patients. They often experience institutional, professional, and social hostility. Although some doctors received support from their institutions and colleagues, that was frequently not the case. In many hospitals across the country, both public and private, the story was one of professional isolation or rejection. In the epidemic's first years, administrators and other shapers of policy acted to distance their facilities from the epidemic, to limit related research, or to reduce patient admissions. They believed that the stigma of AIDS, or the fear it engendered, might tarnish their institutions. They worried that the new disease would repel new house officers, or private doctors, or private donors. AIDS also seemed a threat to establish research commitments and allocation of resources. At NYU, Alvin Friedman Keene, a co-author of the second MMWR on KS, described the fear of administrators that AIDS would tarnish their institution. Quote, "We had a dean at this medical school who, when I presented the stuff at grand rounds about AIDS as the tip of the iceberg, said afterwards, 'Thank you very much for that nice lecture, Dr. Friedman. But why does NYU have to be the Titanic?'" Those who cared for such patients might encounter antipathy from their colleagues as well. Specialists rejected their referrals, trying to hold AIDS at arm's length out of homophobia, distaste for drug users, or fear of infection. The stigma suffered by their patients became a burden with which those who treated AIDS had to contend. Some physicians went so far as to refuse people with AIDS. Ari Rubenstein, one of the prime discoverers of AIDS in children, recalled, "In the beginning, everyone threw their patients at us because they were afraid of them. You take them. We don't want them. We don't want to see them. We don't want to touch them." At Kaiser Permanente in LA, Dr. Neil Schramm, a nephrologist, who was forced to learn infectious disease because medicine to treat AIDS patients, was deeply offended by his colleagues' behavior. When you're dealing with this hideous illness, to be rejected by your physician, to be treated callously, I can't begin to tell you the anger that creates in me. I'm furious with most physicians' responses. And that's why so much of the response to the epidemic has fallen on a limited number of primarily, but not exclusively, gay physicians. In the first decade, antipathy or indifference started at the top. Ronald Reagan did not give a major policy address on AIDS until May 1987, 2 years after his friend Rock Hudson died of the disease, and only at the invitation of another friend, Elizabeth Taylor, co-chair of the American Foundation for AIDS Research. During his presidency, Reagan never used the bully pulpit of the presidency to advocate public support for a national effort against AIDS. In the early years, his administration allotted no extra funding to contend with the disease. By 1985, the U.S. Office of Technology Assessment published a critical report of the administration's efforts. Although the Public Health Service, which includes the CDC and the NIH, had made AIDS its primary health priority, the OTA found that the Department of Health and Human Services had insisted that funding for AIDS research be transferred from other projects. So the increases in research dollars came only at Congress's insistence. In addition, the OTA noted the administration had offered only minimal support for AIDS education and prevention, and had no plans for providing and paying for clinical and supportive services, an explosive problem in light of the exponential growth in AIDS cases. In brief, years into the epidemic, the Reagan administration, to the extent it had responded to the crisis, had limited AIDS to its biomedical aspects. The moral and public health voice of the administration, Surgeon General J. Everett Koop, was for many years prevented from taking a public position on the epidemic by his boss, Assistant Secretary of Health and Human Services, Edward Brand. When, in his second term, critics continued to attack Reagan for his inaction on AIDS, the administration responded by asking Koop to write a report, directly confronting the need for sex education and urging those sexually active to use condoms. Koop further antagonized the evangelical right that had initially supported him and was a pillar of the Reagan administration by refusing to attack homosexuality or blaming gays for the epidemic. Instead, he wrote, quote, "At the beginning of the AIDS epidemic, many Americans had little sympathy for people with AIDS. The feeling was that somehow people from certain groups deserved their illness. Let us put those feelings behind us. We are fighting a disease, not a people." Despite, even because of overt homophobia on the right and covert homophobia in many dimensions of American life, one of the permanent consequences of the AIDS epidemic has been what one gay writer called legitimation through disaster. Moving from the margins of society, the gay community and gay identity became increasingly mainstream. In the absence of sufficient government intervention and absent other claimants, the gay community had little choice but to identify itself with AIDS in order to provide the necessary care and support of its members. Ironically, the stronger its identification with AIDS, the greater the possibility that the community could control the social meaning of the disease, act effectively, and form alliances with groups within the heterosexual majority. By, quote, owning the disease, the community could reconstruct the disease and its relationship to it on its own terms. That response was created within and through gay institutions that already had a purpose and meaning, and by a community with a relatively firm identity and history of struggling against oppression. Like other populations that have their origin in resistance to oppression, the gay community was to a large extent oppositional. It struggled against marginalization, stigmatization, and more positively, it provided a means of self-affirmation for its members. The gay community created social, political, business, legal, and charitable institutions. But one of its most notable features, particularly for gay males, was the profusion of institutions and activities aimed at sex. Because of the historical oppression and persecution of gay sex, the symbolic and social value of these institutions, where one could freely express oneself sexually, was centrally important. The turning point in the gay community history is symbolically associated with the struggle against police harassment sparked by the 1969 Stonewall Inn riot. But by then, community building had already issued and would issue into groups modeled on the confrontational politics of the civil rights, anti-war, and women's movements. Its major aims were to eliminate discrimination and persecution, to remove the stigma associated with homosexuality, and to achieve public recognition of the legitimacy of homosexuals. The deliberative quality of most of these activities represented a desire to tear away the curtain of invisibility. To be invisible is to have no public voice, and thus to be socially powerless, since public speech is central to power in all societies. The eruption of the gay community into public discourse and consciousness was accompanied by the community's will to control its own institutions and life free of outside interference. This demand for autonomy was accompanied by a suspicion of government, which had persecuted and prosecuted homosexuality for so long. The need to work with and pressure government authorities, so central to gay politics during the AIDS epidemic, was initiated with considerable ambivalence and fear. But the fact that the gay community entered into the partnership with a strong history of institutional building and political experience allowed it to create linkages including its association with the dreaded epidemic, with a fair degree of confidence. If the 1970s represented the coming out of the gay community, individuals, particularly professionals, often remained in the closet, if only at work. Homosexuality often remained invisible in medicine, for example. Molly Cook, who became an experienced and committed AIDS doctor working at San Francisco General Hospital, a center of AIDS care, was blind to homosexuality before the epidemic. She confessed to being completely unaware of its presence in her professional work, noting, "My assumption that people were heterosexual was so strong until AIDS pushed sex forward in my experience of medicine." For a number of gay physicians, encountering AIDS forced a confrontation with their own sexuality. Many had gone through medical school fearfully guarding their secret. Lacking senior mentors on whom they could model themselves, they often wondered whether it was possible to be both gay and a doctor, a good doctor. Witnessing the suffering of gay men and caring for AIDS patients could provide the occasion for coming out at work. For John Mazzullo, a Boston-based physician, for example, his sexual and professional identity were worlds apart before AIDS, forced him to end the troubling separation. This is what he said. "In 1983, I started to realize this illness is galvanizing me. I never wanted to be a gay doctor on Park Avenue because I didn't want to do hepatitis and STDs. But this was bigger than all that. And then the other part of the fusion was that I was never a political person. I was too closeted, too frightened, too wrapped up in my own mishigas to worry about the big picture. But this was a political issue. Not only could we all die from this, but they could put us in concentration camps. So I had a medical awakening and a political awakening that occurred between 82 and 84 that was just unique in my professional life. Neil Schramm's observation that gay and lesbian doctors were overrepresented in the epidemic, while the sign of homophobia and the denial of the epidemic's importance on the part of many heterosexual doctors also reflected the moment when some doctors felt empowered or inspired to abandon their invisibility as gay men or lesbians, to forge a new identity and to find a new voice. In March 1983, a CDC report hypothesized that AIDS was probably the product of a transmissible agent. Though the microbe was unknown, the growing number of risk groups suggested a common route of exposure through body fluids, mimicking a known pathogen, the hepatitis B virus. The introduction of that hepatitis model suggested new public health measures or admonitions. These included avoiding sexual contact with persons suspected or known to have AIDS, a strong advisory against needle sharing, and pleas to members of at-risk groups to refrain from donating blood or plasma. The killing fields of the HIV epidemic had already invoked an emotional debate within the gay community over the possibility that the new disease was sexually transmitted, and subsequently demanded a moderation of gay sexual life. In the early 1980s, physicians and scientists who spoke to gay gatherings about the disease and suggested that men should reduce their sexual contacts were cut short. Dan William, I mentioned before, a gay doctor in New York, recalled that, quote, any kind of intrusion on sexual behavior was looked at as an intrusion on one's gayness. Another gay doctor, Joseph Sunabend, ruefully noted, I thought I was being of help, but I was being vilified. I didn't understand it. But the hard-won creation of sexual institutions and the legitimacy of sexual activity would not be given up lightly. In 1981 and 1982, debate within the gay community focused on the wisdom and necessity of changing sexual behavior. Discussions centered on recommendations to decrease the number of sexual partners. Sometimes the debate could become overwrought. In the native of the major gay New York newspaper, two AIDS activists, Michael Callan and Richard Berkowitz, published an inflammatory but landmark article, quote, "We know who we are. Gay men declare war on promiscuity," in which they asserted, what we have is a positive political force tied to a dangerous lifestyle. Despite deep fear, anger, and confusion, the strength of owning the epidemic and having skin in the debate over sex and AIDS permitted the community to register its opinions and dissent in often raucous arguments on a subject so close to gay identity. In 1983, a year later, Callan and Berkowitz published the famous pamphlet, How to Have Sex in an Epidemic, based on Joseph Sonabin's controversial theory that AIDS was a consequence of an immune system collapse following years of hyperinfection with STDs. It strongly advocated in favor of, quote unquote, safer sex that included the reflexive use of condoms. The adoption of condoms during sex had previously been almost absent from discussions of gay sexuality. So much so that even a physician engaged in treating AIDS patients, Ostro from Atlanta, never considered using them. He recalled in an interview with me in a 1983 meeting he attended to discuss the burgeoning epidemic. Quote, "We knew by that point that AIDS was sexually transmitted, but didn't clearly know that we had a responsibility to behave differently. I can remember having sex with another physician there and using Physohex, thinking, well, it's an antibacterial, maybe it will work. Never considered the idea of a condom. Yet the strength of that idea within the gay community, along with safe sex in general, was formidable. And once adopted by public health entities and eventually business, became a powerful motif in the AIDS epidemic. To view the AIDS posters in the current Atwater collection is to see the condom frequently represented and heavily marketed, often with artistry, sensuality, and playfulness, in order to catch and keep the attention of different publics over the long haul. And I'm throwing in this one, not that it's about condoms, but to show how certain motifs persisted. Yet the strength of that idea within the gay community, along with safe sex in general, I'm sorry, I'm repeating myself here. As the epidemic traveled through minority groups, gay and heterosexual, condom outreach became culturally sensitive. Perhaps the most famous campaign to appeal to English and Spanish-speaking young adults was not based on a poster, but another form of public art. I mean the Julio and Marisol comic strip series, modeled on the illustrated books popular in the Latino community, seen for years on the New York City subways. So I'm just going to say parenthetically that the AIDS epidemic pulled on many strands of popular public art, the quilts, which you saw earlier, posters, movie posters, and comic strips, and we'll see more. The new institutions developed within the gay community serve many purposes. The first in New York City, the Gay Men's Health Crisis, like the Shanti Project in San Francisco, was devoted to the care of persons with AIDS, providing social, legal, and counseling services, raising funds, fighting discrimination, and becoming an advocacy force, both on the streets and with political and scientific leaders. As an active agent, the gay community insisted that it have a public presence and voice in all aspects of the epidemic and its management, and that it share power with the outside stakeholders with influence on the epidemic. Such interactions necessarily involve more open discussion of homosexuality, and homophobia. It marked an end to gay invisibility. They subtly increased the authority, credibility, and stature of the gay community, especially as other Americans found that the self-help organizations and the volunteerism created around AIDS were so typically American. Slowly, that recognition began to invest gay identity with a quote-unquote normality it had lacked before. A striking example of the change was a photo essay in Life magazine in 1990 of the death of David Kirby, an Ohio AIDS activist, in the arms of his grieving father. Moving shots that were filled with religious imagery. At the same time, there was danger of becoming too accommodationist or too focused on AIDS. The antidote was for new organizations more confrontational in their demands, impatient with gay entities, raising new issues. Such was the case with ACT UP, which in the wake of AZT in 1987 formed around the demand for new drugs and for accelerating their release as possible cures. ACT UP borrowed its tactics from other organizations, including those of the New Left and the pre-AIDS radical gay movements, making superb use of street demonstrations, symbolic actions, news cycles, and eye-catching graphics like this. Over the years, it had splintered repeatedly, some leading members moving toward more accommodationist positions in the form of TAG, the Treatment Action Group, and others seeking street action. ACT UP began in New York, but groups formed rapidly in other U.S. cities and had impact in other countries. With an ACT UP in Paris and an analog, the Treatment Action Campaign in South Africa. With South Africa, in the minutes remaining, I would like to talk about another permanent result of the AIDS epidemic: the commitment of developed countries like the U.S. to providing treatment and antiretroviral therapy to impoverished populations. In 1996, American researchers demonstrated that a new class of drugs, known as protease inhibitors, when part of a cocktail of medications, could so significantly reduce viral loads that it has turned out patients can live for many years symptom-free. With new highly active antiretroviral therapy, or HAART, HIV/AIDS has become for many a well-managed chronic disease. But the cost of this new chemotherapy was high, well beyond the means of most in income-poor countries or their governments. To paraphrase a South African doctor, if you are a rich man, you get a Mercedes-Benz. If you are a poor man, you walk. It doesn't make that much difference. But if you are a rich man with AIDS, you can buy antiretrovirals and live. And if you are a poor man, you die. That's not fair. The difference within South Africa mirrored the chasm between South Africa and the industrialized world. This profound lack of equity was acknowledged but accepted as a paradigm until the present century. In 1997, Marcia Angel, the editor of the August New England Journal of Medicine, attacked the ethics of a clinical trial in South Africa, in which the control arm received a placebo and the intervention arm a simpler and shorter course of AZT than pregnant women received in the U.S. There, a randomized clinical trial had already shown that AZT cut mother-to-child transmission of HIV by 2/3. Angel and the other critics charged it was unethical to offer placebo to controls in poor countries when AZT had been shown to be effective in the countries sponsoring the research. Those who defended the trials argued that South Africa, which had the highest number of AIDS cases in the world, and where 48% of women in one province were HIV positive, could not afford the cost of the American dosage. The trial was to test as clearly as possible whether a more moderate dose of AZT, affordable to the country, would prevent pregnant mothers from infecting their fetuses and newborn. Remarkably absent from Angel's discussion was the inequity, not of the trials, but of the disparity of resources that condemned so many to death because of the country in which they were born. In a matter of years, that paradigm shifted. In South Africa, the Treatment Action Campaign, TAC, mentioned earlier, and Doctors Without Borders, as well as local AIDS doctors and a few paternalistic corporations, pushed, prodded, and embarrassed pharmaceutical companies to lower their antiretroviral prices. Not incidentally, these companies, many of whom had plants in South Africa, faced potential competition from generic manufacturers and feared for their market share. With prices declining and funding from foreign countries, South Africa, the richest country in sub-Saharan Africa, could have afforded public purchase of heart. But as Donna Milvan said earlier, everyone was resistant in stages. In a stunning reversal of his previous position, Thabo Mbeki, the president of South Africa following Nelson Mandela, expressed skepticism that the HIV caused the disease, and with his health minister, succeeded in blocking heart treatment in the public sector, on which most AIDS patients depended. To doctors and nurses who were members of the ruling African National Congress, even during the years of the anti-apartheid struggle, for their new democratic government to withhold life-saving drugs, much like the old National Party, was a shock against which they struggled both personally and for their patients. No group was more vehement in opposition than the Treatment Action Campaign, so influenced by ACT UP, which used the courts, media, streets, confrontations, theater to force the Mbeki government to change course. Its leader, Zaki Ahmad, although HIV positive, made the moral commitment to reject heart until it was available to poor South Africans. Like the gay community in the US, Ahmad, an anti-apartheid veteran, and TAC, like the gay community in the US, Ahmad and TAC forged alliances with powerful community and political forces, including Nelson Mandela, Doctors Without Borders, elements within the ANC, the media and medicine, the press, for a sane AIDS policy. Mbeki, under pressure from the progressive wing of his own party and international authorities, retreated from the denialist position, even while Health Minister Manto slowed down a national rollout of heart and strenuously favored alternative therapies, you see here, like garlic, onion, lemon, and vitamins. Both Mbeki and Manto were eventually repudiated by the ANC, but only after scathing criticism, which included the brilliant political cartoons by Zapiro, one of which is up there, and the death of hundreds of thousands of AIDS patients. The commitment of the developed world to treatment and research in Africa and Asia is a significant paradigm shift. Yes, it serves Western interests, but it gives life to a substantial number of families. The New York Times last week reported that Congress hopes to double the number of people covered with heart from 6 to 12 million. These are impressive numbers, but there are 25 million living with AIDS in sub-Saharan Africa alone, living with AIDS. As we view the beautiful collection of AIDS posters, let us remember they are also artifacts of a current, not just a past, pandemic, one that is devastating the lives of people who are already devastated. The immensity of the carnage, who already suffer severe deprivation. This is the living epidemic that we testify to tonight. It's past and present. So that, in the words of Dr. Rieu in Camus' The Plague, we testify the following: we should not be one of those who held their peace, but should bear witness in favor of those stricken people so that some measure of the injustice and outrage done to them might endure. Thank you.